Okay, back to the drugs. The drugs for seizure disorders act by stabilizing the nerve cell membranes, so they prevent the spread of the epileptic discharge. About a third of the patients are going to require more than one medication, but we would start them on one. Some drugs require blood levels to be drawn to determine, the therapeutic range, but the newer drugs typically don't. They have a very narrow therapeutic range and probably won't require a blood level. Drugs for seizure disorder, again, they've got to be taken regularly. Some patients, if they haven't had a seizure for a while, they start feeling good, they stop taking their medications, and then they start to seize again. So it's really important to teach your patient that they need to stay on the medication. There is a pretty good list of drugs in your textbook. It's called the drug therapy table. And that shows the drugs for the generalized, tonic, clonic, and focal. And then there's a short list of just 4 drugs used for absence or absence and myoclonic seizures. But some of the common drugs that you will see are the phenytoin, carbamazepine, phenobarbital, divalproex, and primidone. And remember that I mentioned that for NCLEX purposes, we will be going by the generic name of the drug. So be familiar with these drugs, learn these drugs, but learn them in their generic names. And so just some of the drugs for the myoclonic or the absence seizures would be ethosuximide, divalproex, and clonazepam. Some of these drugs are broad spectrum and they may be used for multiple seizure types. Here's some more of the broad spectrum drugs. Keppra is one that I've seen really commonly used. Lyrica is an additional treatment for focal seizures. It's not a single medication, to be controlled just with that, but it's an additional treatment. Because Ativan and Valium are short-acting, they need to be followed up with long-acting medications to control status epilepticus. And remember, status epilepticus is an emergency requiring medical intervention. And so it will be IV lorazepam or diazepam that may be used to get that seizure activity to stop. Anti-seizure drugs should not be discontinued abruptly because that can actually cause a seizure to occur. Some common side effects of the medications involve the CNS, and they include diplopia, which of course is double vision, drowsiness, ataxia, which is uncoordination, and mental slowing. So what are the hallmark symptoms of WL's complex seizure, and what patient teaching would you need to do with him? Remember, in the complex focal seizure, going back to the algorithm, patients have a loss of consciousness or an alteration in their awareness, like a dreamlike state. Their eyes are open, they may be moving, but they're not going to answer questions or interact with anybody. They may demonstrate, like as in his case, something like lip smacking or other repetitive, purposeless movements called automatisms. And some people may do things that are embarrassing and or dangerous, like walking into traffic, removing their clothes. Patients may continue an activity that they started before the seizure, like say they're counting coins or taking things off the shelf in the grocery store, but they don't remember the activity that was occurring prior to the seizure. And again, these seizures are like 30 seconds to 2 minutes in length. Patient will be tired, may have some confusion. So you can teach them about what to expect in future seizure episodes and the possible treatments. So it's very encouraging for patients to know that seizures can be controlled with medications. So some considerations for the geriatric population. Phenytoin may be problematic. Older adults, their metabolism tends to slow. They're not able to process toxins as well as younger people. So they can have, they also may have compromised liver function from medications or other issues. But the liver metabolizes phenytoin. So if there's compromised liver function, then that's something that would probably be not recommended in the gerontologic population. Phenobarbital, carbamazepine, and primidone have potential effects on cognitive functions, so their use may also be less desirable for older adults. Also, some of these medications can increase the risk of osteopenia and osteoporosis in older adults, which we know is one of the big reasons for the fractures, the fractured hips and things that we do see in that population. So there may be newer medications that are safer for older adults. Here's a few of those. I mentioned earlier that surgery may be an option for some with uncontrolled epilepsy. So a substantial number of patients with uncontrolled epilepsy may be candidates for surgical therapy to remove the focal point where this abnormal activity is occurring. The classic surgical intervention has been an anterior temporal lobe resection. The current goal of neurosurgery is a careful resection of a precisely localized area within a lobe of the brain. And there's a very high success rate. About 70 to 80% of people are seizure-free after having this procedure, and 10 to 20 have a marked reduction in seizure activity. So it looks like it may be very promising for many people. It's not for all types of epilepsies. There's 3 requirements for surgery. First of all, there has to be a confirmed diagnosis of epilepsy. They have to have first tried drug therapy without satisfactory results, and they have to have defined electroclinical syndrome. And that's a type of seizure disorder. Vagal nerve stimulation is another type of therapy. It can be used in addition to medications if surgery is not feasible. It's a form of neuromodulation, so it's used as an adjunct or in addition to the medications. It's thought to interrupt the synchronization. Remember I said that it affects both sides of the brain, so it's synchronization of epileptic brain activity, and it's supposed to stop the excessive discharge of neurons. So in vagal nerve stimulation, there's a surgically implanted electrode in the neck, and it's programmed to deliver an impulse or an electrical impulse to the vagus nerve, and the patient can activate it with a magnet whenever they think they're about to have a seizure. So for your nursing assessment, when you are doing a focused assessment on a patient who has a seizure disorder or who has had a seizure, new seizure, find out if there was any birth defects or injuries at birth. Have they had any anoxic episodes? What's anoxic? Their brain was starved of oxygen. Has there been any CNS trauma or infections, stroke, metabolic disorders, alcoholism? exposure to metals or carbon monoxide, and hepatic or renal failure. We want to find out if they have been in compliance with their anti-seizure meds, if they have been on them. So if they've stopped taking their medications, they begin to seize again, or have they been using barbiturates or alcohol and now they're in withdrawal. Cocaine and amphetamines are other drugs that may precipitate seizures. Talked a little bit about the genetic link. We're going to ask them about their family history, ask them about precipitating events like headache, aura, mood changes, behavioral changes, if this has caused anxiety, depression, loss of self-esteem, and isolation. So here are some other things we talked about at the beginning that may be precipitating factors. Some of the things that we may see are bitten tongue during a seizure. The patient may bite their tongue or their cheek. They may have cyanosis because of not getting enough oxygen during the seizure, not breathing because of an abnormal respiratory rate. And then they may have apnea. Well, there again, where there's periods of not breathing during the ictal phase. Do you remember what the ictal phase is? If not, look that up. Look up your phases of the seizure. Make sure you're familiar with those. So the breath sounds may be irregular, and there may be some airway occlusion. They may demonstrate, or they may have hypertension. They may be tachycardic or bradycardic. They may be incontinence. I mentioned excessive salivation, weakness, paralysis, ataxia, those things you would see in the postictal phase. And there would be abnormal findings on your CT, MRI, and EEG. There we would be looking for those things. They don't always find anything abnormal, but we would be looking. So again, the tonic-clonic is a loss of consciousness, muscle tightening and then jerking, dilated pupils, hyperventilation and then apnea, and then somnolence after the seizure is ended. The absence or absent seizure, altered consciousness, that's that where the patient or the child looks like they've just kind of spaced out for a little bit. Simple focal seizure may be precipitated by an aura, and it may start on one side and it may stay in one place, or it may affect, it is unilateral, so it will stay in one place. With the complex, there's going to be altered consciousness, inappropriate behavior, automatisms, and again, all of these things are on that algorithm in the first couple of pages of the seizure section of this chapter. So some of your nursing diagnosis may be ineffective breathing pattern, ineffective health management, and risk for injury. I mentioned earlier that, these patients may suddenly fall to the ground. Maybe they're on a staircase, maybe they're on a hard surface. It is possible that they will sustain injuries, so that's going to be your priority. Remember, during the seizure, you are timing it. When did it start? When did it stop? How long did it last? What did you notice before it started? What did you notice when it ended? So the overall goals are, of course, are to be free from injury if they do have a seizure, and to have optimal mental and physical functioning while they're taking their medications, have satisfactory psychosocial functioning. We talked about the feelings of alienation, anxiety, and depression, the fact that they can't drive, those things that may affect their psychosocial wellness. So some of the things we may need to promote for safety measures are wearing a helmet if they're at risk for a head injury, diet and exercise, just general health habits, and help them to be able to identify events that may predispose them to a seizure and to avoid them if possible. Tell them they need to avoid alcohol, becoming overly fatigued, or not getting enough sleep. So again, observe, treat, and document.